Yes, so good morning, and thank you, Miriam, for that introduction. Um, as Miriam said, I work for the Malaria Alert Center in Malawi, and this morning I'm just going to talk a little bit about malaria in school-aged children, the impact on health and education. Basically, what I'll be doing is really to set up the platform for my colleagues that are going to talk more about some of the interventions that are there. So I'll concentrate in looking at the literature that is already there on malaria and health, and then just maybe introducing some of the interventions that can be done, and talking a little bit about some of the school-based malaria treatment program that I have been involved in Malawi. So just as a matter of introduction, I think historically malaria control and research has really mostly focused in under 5 children, has been focused in under 5 children, mainly because this is where you have the highest burden of disease. But as transmission is going down in sub-Saharan Africa, and as we roll out most of the interventions, I think we are seeing more and more of disease within the other age groups, most especially children that are older than 5. Unfortunately, because a lot of the research is taking place in under 5 children, there is really very little that we know about malaria within this school-aged group. The reason why we have this symposium, really to start thinking and looking at what other studies and can be done within this age group. Yet when you think about it, this is, I think, the ideal group that we need to be dealing with, mostly, especially because, one, you're talking about almost 200 million children that can easily be accessed through schools in sub-Saharan Africa, and the payload in terms of health impact would be great if we could get interventions through these schools. So this slide basically is just a summary of some of the surveys that have been done. I have to mention the fact that traditionally surveys are not routinely conducted within this age group. It's only of late that there have been studies that have looked at the parasitemia within this age group. But if you look at that across the whole of the sub-Saharan region, you are looking at quite high parasitemia rates within the school-aged group, from about 30% in Uganda all the way to about 80% in parts of Mali. In Malawi, where I work, we've looked at malaria in randomly selected schools, and you're talking about almost 60% of children having parasitemia within that age group. Now, when it comes to burden of disease, again, it's kind of difficult to know the incidence of malaria within this group, because usually things are not reported within the HMIS specific to this age group. But what you usually get is maybe through surveys, surveillance surveys that are being done in parts of the, especially by research groups. So this is just a surveillance study, results of a surveillance study that we were doing in Malawi across 3 districts, really. Chikwawa being a high transmission area, Cholo low transmission area, and Ndilande being an urban setup. But even if you look at that, you see that the pattern of disease is extremely high, especially in the 5 to 15 years old. So those that are coming to the clinic with malaria symptoms, highest proportion of those with malaria disease are actually within the 5 to 15 age groups. In terms of mortality, again, we don't know much because there isn't a lot of research being done within this age group as well. But we know for sure that based on the other estimates, WHO and the other modeling studies, almost 50% of the deaths that are happening within this group are actually from school-aged children, and 10% of all the malaria deaths are coming from there. Within our setting, we have tried to look at case fatality rates and found that that age group that we are interested in actually is one that has got the highest case fatality rate, even when we compare that to under 5 children, where traditionally we have done a lot of work in. This slide is just highlighting the issues to do with the educational effects, malaria on educational attainment within the setting, and we know that malaria is going to affect education within this setup because of issues to do with absenteeism. In Kenya alone, they estimate that as much as 10 million school days would be lost because of malaria. Cerebral malaria, of course, has got an impact on the issues to do with speech, language, all of these which are going to affect education attainment. So, looking back now at the use of bed nets within this setup now, the use of interventions. Basically, this is, again, a group that is not using the interventions. If you look at these slides, this is highlighting several studies, several surveys done in Malawi. And what you see is high parasitemia. But when it comes to looking at bed net use, you're not seeing much use there compared to the other age groups. Actually, the age groups where malaria parasitemia is lower are the ones where you're seeing higher use of bed nets compared to those that have got high parasitemia. Again, even access to treatment is an issue. Several studies, the surveys that we've done, basically point that this group will hardly report an illness. But when they report as well, most likely they are going to seek treatment in non-traditional places away from the formal health sector, in places like shops and all that. So what can be done? Several things can be done. And as I said, this is just laying a groundwork for my fellow colleagues to talk about other things, other interventions. But I'll just say that there are things that are already being done. If we look at ITNs, for example, that's groups that are distributing bed nets through schools, and others distributing bed nets actually through mass campaigns, all of which aimed at increasing utilization within this group. Again, highlighting the fact that even though there are all these efforts, it's still utilization of services, utilization of bed nets within this group is at a lower level. If you are in an area where seasonal malaria chemoprophylaxis can be done, then that's something that colleagues are doing. And again, we're going to hear a little bit about that. We're going to hear a little bit about IPT. We're going to hear a little bit about intermittent screening and treatment from colleagues that will be presenting as well. But I just wanted to briefly talk about something that we hardly talk about, which is case management within the facilities, within the school facilities themselves. So basically, I wanted to just share with you results of a study that we did in Malawi. Basically, this study was a cluster randomized trial where we tried to do case management within schools using teachers, capacitating them to do RDTs and treat those that had malaria. And then basically we wanted to see what the impact of that is going to be on child absenteeism, well-being, health, and education within the setup of Malawi. So basically, what a learner treatment kit is just a tool. It's just a kit where you have the basic things, the first aid kit where you have the basic things. Usually, it would contain things like paracetamol, ORT, and maybe eye ointments. And then stuff to do with the wound management or injury management would be in there. But what we did in Malawi was really basically to capacitate these teachers in doing treatment of malaria, so being able to do RDTs. So we provided them within this learner treatment kit, ACTs, RDTs, weighing scales, and made sure that they knew how to do this and then and implement within the schools. So at each school, we had about 2 to 4 teachers that we trained over a period of 7 days. The training itself was offered by the Ministry of Health, and a refresher course in the middle of the implementation period. The schools themselves were attached to local health facilities where they could get supplies and where they could get as well the supervision from. And basically, we only allowed them to proceed and implement this after we had certified that they were able to do this safely and implement the program within this setup. So we implemented this over a period of 4 terms. A term, usually a school term, is about 3 months in Malawi. So we implemented this between January 2014 to 2015. Training was done before and in the middle of that. And then we looked at the attendance based on the teacher-recorded attendance. And of course, we did some unannounced attendance spot checks as well, just for us to be able to measure some of the outcomes. And of course, child-reported well-being within there. More especially as well, we did the cross-sectional surveys at the end of 2015, in the early of 2015, just for us to look at the impact on the other aspects like anemia, parasitemia. So in a nutshell, if this slide here just shows the high burden or the high need for such kind of service within schools. If you look at the first term there, you had something like 12,000 consultations within the school clinic itself. And for those that we are looking for, those that had symptoms or signs of malaria, you're looking at almost 80% of those coming with those symptoms. And when we did an RDT, you can see the high levels of parasitemia or high levels of malaria within that group, almost 78% in the first term. It still remains the same across all those seasons. High burden of malaria within this setup. When we looked at the effect of this on the child absenteeism, we are not really able to show whether it had any impact on child absenteeism. Again, we attribute some of this maybe because of the method itself. We asked the teachers to do a lot of the documentation, but because of other responsibilities, there were quite a number of issues that were associated with teacher-reported absenteeism. When we looked at the effect of this on the malaria, parasitemia, anemia, and of course on the educational outcomes such as numeracy, we were not really able to show any impact of this intervention. But when it comes to looking at the impact of this in terms of providing access to health care to kids, you can see that a lot of the kids who traditionally would not have gotten any kind of treatment, or if they were to get treatment, they would go and look at it from shops, were able to get this kind of treatment within the school parameters. But at the same time, being able as well to continue with their learning whilst they are getting treatment and they're being managed by malaria. So what summaries what lessons do we learn from this? I think one of the key lessons that came out for us is just the key issue that there is really a need for something like this within the school setup. I know we talk about other interventions. Usually case management is not something that people will talk about within the school setup, but there is definitely a need for this because of the high number of people that came for consultations and the interest that was shown in the whole program. We were not able to show any impact in daily attendance, but we attribute that maybe to our evaluation design and all that as maybe being the cause of why we were not able to show that impact. Teachers, we were able to show that they can comfortably do this. They were comfortable doing it themselves. It was acceptable to them to do this. Parents and the children were happy actually to get the treatment from this group. Currently in Malawi, there is now discussions as to whether this would be something that can be scaled up. Although we didn't show any impact, but I think there's quite a lot of realization that this is something that definitely would add value in terms of improving access to treatment within this age group. Of course, we would have to think through how do we manage this in terms of how do we provide, let's say, RDTs through to teachers who will be supervising them. What kind of incentives would be available for them to be able to continue doing this? I'm saying this because as we went along and these few teachers were doing this, they realized that they were doing more work compared maybe to the few colleagues that were not doing this. So there was that need and the request for incentives that needed to be paid. We would have to balance that and see how best we can do that so that we are able to implement this and do it sustainably. So, and of course, convincing other donors that might be interested in this. In Malawi, of course, the buy-in is there by the ministry, but there are others as well who feel that we might be taking away teachers from their core responsibility to doing something else when actually they are most needed actually in the education sector itself. So in summary, I just wanted to share with you these results and highlight the fact that as the other interventions are being described by colleagues, there is this other intervention as well that we tried within our setup. We didn't show any impact in terms of the education outcomes. It is something that is worth repeating in other places, but it's something as well that would greatly improve access to treatment within the schools. I just wanted to acknowledge the many colleagues that I've worked with, especially when it comes to school-aged children. We have the Malawi ASTMH, Save the Children, London School, Ministry of Health and Ministry of Education colleagues that we have collaborated on many surveys that we do within Malawi, within this age group, and as well collaborated on them with various interventions that we are doing and plan to do in future. Thank you.
Looks like we have one pressing question. Go ahead.
Thank you very much for the presentation. I've got a little bit of sort of cognitive dissonance. Maybe it's just the time in the morning. But you started off by saying, making a good case, we don't know as much about malaria in this age group, okay? And then you show a trial that should have been, help us understand that conceptual framework that you put out, right? Putting some empirical evidence on that. You found no impact, and then it sounds like you're ignoring the results of your trial. But yet, if you started off by saying we don't know that much, is it possible that your trial is actually telling us something, and maybe we need to rethink that conceptual framework? I don't have an alternative explanation why you didn't find anything, but I'm just wondering, maybe the evidence is actual evidence.
Okay. Yeah? All right. I think, one, when it comes to the trial itself, there is no question that the methods that we used, especially in relying on teachers to document attendance and all that, there were issues with that. So the lack of impact from that angle is something that maybe we really cannot say that there is no impact. One would want to try this in other places as well. Again, emphasizing the fact that as far as I know, case management within schools is not something that has been tried on. Previously, in Malawi, we have tried this using SP, but we haven't really tried using this, let's say, doing RDTs and using SCTs within the schools. So maybe what I'm trying to drive it would be nice if something like this was to be tried elsewhere. But what I'm trying to say is when you look at the sheer number of people that were within schools and wanting treatment, who were coming to school every day to learn, but actually we are sick, one would want to think about this and moving this forward. because it would really provide access to treatment to so many children that would require.
Sure. Yeah, I have no qualms with that. Increasing access in a big way, that's a great thing.
Yeah.
I'm just wondering whether we might be ignoring the possibility that maybe the relationships between infection and absenteeism and other things are, maybe we really don't understand it as much if a study like this, anyway.
Yeah.
So this is an excellent question, and really the point of this whole symposium is to sort of say, what do we know, what don't we know, are there more studies to be done, or are there not more studies to be done? So I'd like to propose that we wait and ask questions at the end. We'll have plenty of time at the end for discussions, because I think that every speaker will contribute a different part to this picture. So thanks so much, Don.